Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article BTK Z481S mediated resistance to ibrutinib in CLL by Jennifer Woyach et al. My name is Adrian Wiestner. I'm the chief of the lymphoid malignancies section in the hematology branch of the National Heart, Lung, and Blood Institute in Bethesda, Maryland. My oncologic specialty is chronic lymphocytic leukemia and related B-cell malignancies. Ibrutinib is FDA approved for all patients with chronic lymphocytic leukemia, or CLL, and is rapidly transforming the therapeutic approach. Ibrutinib covalently binds to Bruton's tyrosine kinase, BTK, and thereby irreversibly inhibits kinase activity. BTK is an essential intermediary for intracellular signaling pathways that drive disease progression and CLL cell survival. In randomized studies, ibrutinib improved survival of relapsed or refractory and treatment-naive patients compared to the respective control arms. Particularly noteworthy is ibrutinib's activity in high-risk patients, such as those with deletion 17p. However, resistance to ibrutinib occurs in a subset of patients. Patients at highest risk of treatment failure are those with relapsed or refractory disease with deletion 17p, often with additional risk factors such as complex karyotype or advanced stage. Resistance in previously untreated patients appears to be uncommon, and in our own experience, this is true even for patients with deletion 17p who receive ibrutinib as first-line therapy. Treatment failures on ibrutinib fall into two major categories. Transformation into aggressive lymphoma, also known as Richter syndrome, tends to appear early, while progression due to the emergence of drug-resistant CLL clones appears later. Previously, Woyach and others reported mutations in BTK in patients with progressive CLL on ibrutinib. The most common of these mutations, C481S, changes the cysteine at position 481 to a serine and thereby prevents the covalent binding of ibrutinib to the kinase domain. In addition, they also found mutations in PLC-gamma2, a downstream mediator of signal transduction activated by BTK. These mutations bypass the effect of ibrutinib and restore proliferation and survival signals in the CLL cells. In this issue, Dr. Woyach and colleagues report on incidence and patterns of ibrutinib resistance in a cohort of 308 CLL patients treated at their institution. At a median follow-up of 3.4 years, 83 patients, that is 27% of all treated, developed ibrutinib resistance. In 27 patients, that is in 9% of all patients, progression was due to Richter syndrome. In 55 patients, or 18%, progressive disease was due to CLL. As seen in other studies, transformation appeared within the first 2 years and progression due to CLL later. The estimated cumulative incidence of CLL progression at 4 years was 19%. Among patients with progressive CLL, resistance mutations in BTK or PLC gamma 2 were identified in 87%. Interestingly, in a subset of patients, multiple mutations were present in the same CLL clone, indicating the concurrent emergence of different drug-resistant subclones. A second important observation is that mutations were often detectable in stored blood samples many months before patients met criteria for clinical progression. In fact, the median time between the first appearance of a mutation and clinical progression was 9 months, ranging from 3 to 18 months. Based on these observations, the investigators started to monitor patients for resistance mutations using a CLIA-certified sequencing test. Confirming their retrospective analysis, routine monitoring prospectively identified mutations at low frequency in some patients who had no signs of clinical progression. With continued follow-up, the fraction of drug-resistant CLL clones invariably increased, and half of the patients followed in this manner eventually developed clinical progression. These data suggest that molecular monitoring could be helpful to identify patients at risk of treatment failure, who then might benefit from intensification of treatment. Ibrutinib is clearly a major advance for patients with high-risk CLL and those who relapsed or were refractory to chemotherapy. With longer follow-up, the emergence of drug-resistant clones identifies a new subset of patients in need of novel therapies. In the first reports, patients who developed resistance to ibrutinib had a short median survival of less than 1 year, likely reflecting the late-stage disease in many of the patients enrolled in the early trials. Dr. Woyach and colleagues now report a median survival of almost 2 years for patients progressing with CLL. The improved survival is likely due to the availability of alternative active agents such as the BCL2 inhibitor venetoclax and the increasingly swift transitions of relapsing patients to subsequent therapy. Patients progressing with Richter transformation unfortunately continue to have very short survival, but early results with checkpoint inhibitors or CAR T cells are promising. In contrast to the cohort of mostly relapsed or refractory patients reported here by Woyach and colleagues, few patients treated with ibrutinib in first line have developed drug resistance. However, duration of follow-up in the first-line setting is still quite limited and long-term data is awaited. Hopefully, drug resistance will remain rare for patients with previously untreated CLL. In patients having relapsed after chemotherapy, especially those with adverse prognostic features, combination therapy may be required for long-term disease control. The data reported by Woyach and colleagues suggest that patients at high risk of treatment failure, and certainly those developing ibrutinib resistance, benefit from close observation and inclusion in clinical trials. Continued rapid progress in therapy should be possible given the expanding choice of active agents and the availability of ever more sophisticated tools for molecular monitoring. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.